Okay. Hey guys. Chapter 11 is poisoning and substance abuse. I'm gonna try to cruise right through this thing. There is a lot in it. Take your notes. I'm gonna try to point out important things to you like always, but try not to read every slide. So, if I can hang on just a second. Okay, now I think I'm ready. Maybe if I can get my computer to work. Okay, here we go. So, some of the things we're going to go over is carbon monoxide poisoning, nerve agent poisoning, um, and how and when to contact poison control. Um, Immunology, sorry, I can't talk again. Pharmacology, medication administration, self administration. So you're giving it to someone or you're assisting, so peer administration. Um, we're going to talk a little bit about within your scope of practice as an EMR. You need to know the name of the medication, what it does, so the effect it has, indications. So when is it okay to give it? Routes of administration. So how do we give it, and the dosage of the medication that we're giving. So what is the correct dose? What are you allowed to give, and why are you giving that amount? Um, so a poison is a substance that causes illness or death when it's eaten, drank, inhaled, injected, or absorbed, and it can only take small quantities and still be very dangerous. EMRs can save patients' lives by quickly recognizing a problem, along with anything else that we've talked about. Recognition is one of the very first things we do. Um, in case you guys haven't caught on yet, we are going to do patient assessments on every single patient. It's every single patient, no matter what's wrong with them. We do a patient assessment. So, poisoning can be classified according to the way the poison enters the body. So we've got ingestion, inhalation, injection, absorption. So when we ingest it, it goes in through our mouth. We eat it, we swallow it, whatever. We inhale it, we breathe it in, so it's going into our lungs and it's getting that mucous membrane. Uh, Injection, we're shooting up, or it's entering the skin in some way, or absorption, it actually soaks in through pores and gets in our circulatory system that way. So nothing changes on your patient assessments. We did patient assessment back in chapter 9. We're going to hound this every single chapter because it's one of the most important parts of the job. So as always, we start with that scene size up. BSI, is my scene safe? What's my mechanism of injury or illness? How many patients do I have? Do I need to call additional resources? And do I need to consider C-spine? That right there, your scene size up. And we're going to continue primary assessment. That's our ABCs, our general impression, all that. History taking, secondary assessment, and then reassessment. On this one, the do I need additional resources can actually be really important, because do I need a hazmat team? Do I need poison control? Is this a dangerous situation where illegal drugs are involved and I need law enforcement? So that's kind of an important one here. General assessment. So follow the patient assessment sequence, like we just talked about. Obtain a thorough history from the patient or bystanders. Let's find out, is this was this an accident? Are they known for using illegal drugs, or are they confused and they accidentally overtook their medicated drugs, their prescription drugs? Let's talk to the patient. If the patient's alert and oriented and we can get information, awesome. If not, let's use family, let's use bystanders, whoever we can. Be alert for visual clues that may indicate the poisoning. So we talked about it. As soon as you arrive on a scene, you need to scan that scene. You need to notice everything you possibly can. It's kind of like playing that game where you have two pictures that are the same, but there's hidden stuff in one, or something's missing or something's added. That's what we do on every scene. We scan that scene and we find every clue we can to what's going on. Much of the emergency care depends on the patient's signs and symptoms. That is very true in this case. Um, Sorry, I was looking at my phone. The more we can learn immediately, the better we can treat that patient quickly and safely. So a couple of things, we want to look for trace substances on the skin. We've got to be wearing our gloves. I'm going to tell you, we probably would want some sort of mask on if we're going into somewhere we know that there's been drugs. Needle pricks and sticks, we got to really watch for used needles. It does happen. And then respiratory distress is a big one when we're doing with poisoning or drug abuse, because of what a lot of the drugs will do is it goes in. We're not going to get into details, but it will actually slow the respiratory drive down or stop it if there is a bad overdose. So we need to pay close attention to the respiratory system. So I'm not going to read all those. You can look at them. They're in your book. Just kind of breaks everything down. So according to the CDC, there are 70,737 drug overdose deaths in the United States, and that was in 2017. Since then, it has actually gotten worse, and I think it talks here in a minute about that. But in 1999, there were 6.1 drug overdose deaths per 100,000 people. And then in 2017, that increased to 21.7 drug overdose deaths per 100,000 people. And here we are in 2024. I don't have a number, but I'm sure it's higher even now. Most deaths are due to opioids, so your fentanyl, heroin, oxycodone, morphine, and hydrocodones. They're easy to overdose on. People want to get a high. It shuts their respiratory drive down, and they eventually succumb to their overdose. So what has been the experience in the EMS district? We see more and more overdoses, and especially in younger and younger people. More than 80% of all cases of poisoning are caused by ingestion. So what is ingestion? That's when we are swallowing it. It's going in into our system by mouth. We're absorbing it, just like we would a food or anything else. Let's see, chemical burns, odors, and stains may be found around the patient's mouth. So we're going to look for unusual breath odors, nausea, vomiting, abdominal pain, diarrhea, discolorization, or burning around the mouth. They're going to have look really chapped lips, or they're going to have white substance around them, or they're going to be red and puffy, like they're swollen and burned. We got to pay close attention to our ABCs here. We really, really need to pay attention to the A's and the B's. We got to keep that airway open and that we have adequate breathing. Treatment for these poisons, if you can, let's identify that poison the best we can. Let's call the National Poison Control. There's the number. For instructions, and follow those instructions. You can also call your medical director. He is going to tell you to call poison control, though, he or she. If you're unable to contact poison control, let's dilute the poison by giving some water. Arrange for a prompt transport. So if you are not with the service, like an EMS service, if you're just the EMR that happened to respond to this and you're waiting on EMS, go ahead and get 911 on the phone, or if you know who's responding, call them, let them know what you found, let them know what you did. Activated charcoal is something that a lot of services carry. My service does not. It's a finely ground powder mixed with water. It works by binding to the poison, therefore preventing the poison being absorbed. So it gets flushed out. Do not give if the patient has ingested an acid pH of 7.0 or a base of 7.0, has ingested a petroleum-based product, or is unconscious. Activated charcoal, so the dose for adults is going to be 25 to 50 grams, 12.5 to 25 grams for a pediatric patient. Serve it in a covered cup and give the patient a straw. I would definitely be telling that patient, hey, this isn't going to taste very good, but you need to swallow it. Because if you're giving this, they're awake, they're alert, they're following commands. So I would definitely be open and honest with them. Sorry for you. It's going to be bad, but you've got to get it down. It's that simple. Vomiting. Do not do anything to provoke vomiting. I highlighted those because I can never pronounce that word. So the American Association of Poison Control does not endorse the use of whatever. It invokes vomiting. I never can say the word. So big picture here that we want to take away from this slide is vomiting is not good. We don't try to make them vomit. We don't stick our finger down their throat. We don't give them anything that causes them to vomit. It's already went down. We don't want to come in. That's the big picture. So inhaled poisons, this occurs when toxic is breathed in. It's absorbed in our lungs, that mucous membrane. That's how it gets into our body system. So things like carbon monoxide are super poisonous. We've got other gases, chlorine gases, ammonia, super irritating to the respiratory tract. You're going to get coughing and severe respiratory distress, eyes burning and watering. So chlorine gas, we use our chlorine in pools and stuff. Ammonia, we're going to find them on farms at co-ops. You see them big anhydrous tanks. Those have ammonia. So we need to be very careful. Once again, on my soapbox, if you run up on a car wreck or a farm accident and you see one of those tanks or you see something that has a placard on it, we need to stop what we're doing. We need to figure out what's there. Because the last thing we want to do is have an EMR run in and collapse because they took a deep breath of any of these toxic gases. And then I show up and I'm all excited and I run up to help you because you're the EMR and I'm going to help you. And then I go down and it's a domino effect. And we don't want to do that. So signs and symptoms: respiratory distress, dizziness, cough, headache, hoarseness, confusion, chest pain. In some cases, you're actually going to take a breath and pass out. It's that fast. Carbon monoxide. So this is going to be on a quiz or a test right here. The leading cause for carbon monoxide poisoning is improper vented heat appliances, smoke from burning buildings, of course. Inhaled small quantities of CO can be dangerous due to the ability to bind hemoglobin and red blood cells. So we talked about that during respiratory. When we put that pulse ox on someone and we get a reading of 100 and we have a suspicion of carbon monoxide poisoning, it's because carbon monoxide will bond to hemoglobin better so than oxygen does. So if you will, it crowds on that hemoglobin and it won't let oxygen on. There's no room for the oxygen, and that carbon monoxide is what our pulse ox is actually reading. Treatment for that is we are going to flood them with oxygen and try to get as much oxygen on that hemoglobin as we possibly can. Signs and symptoms: you're going to have headaches, nausea, delusions, unconsciousness, flu-like symptoms. If you find several patients together, it says to remove everyone from the structure or vehicle. That is only if it's safe to do so. If they are able to communicate or move, I will have them come to me rather me go to them, because you're walking into a bad deal. You're not going to see it or smell it. You're just going to, you get the effects of it. Let's see. So a lot of confusion or altered mental status can come with this as well. Irritants. So ammonia, we've talked a little bit about, often found in agricultural settings, strong, irritating odor, and it's highly toxic, causes violent coughing, can severely burn skin. Anyone who enters the environment containing ammonia must wear the proper encapsulated suit and a SCBA, which is your full respiratory air tank and everything, like your firefighters will wear. As an EMR, as an EMT, advanced EMT paramedic, we do not just go driving into these environments. Once again, we make sure our scene's safe. So here you just got a picture of right here. This, is one of them tanks I was talking about. And then here you see they are completely encapsulated. They've got their air tank, they got their full face mask with their air hose. These guys are the ones that go into this disaster. Okay. We do not just run in there and help people if it's dangerous. Chlorine, it's found around swimming pools and water treatment plants. Severely irritating to the lungs and upper respiratory tract. You're going to get violent coughing, burning sensation, can cause skin burns. You're going to get the watery eyes. Once again, right here, I'm loving having this highlighter. I use it. Right here, we need a self-contained suit with that SCBA. So presence of hazards material. So we've kind of hit on a little bit toxins or like train cars, semi trucks. You're going to see these placards on there. Each ambulance is going to have this right here. I actually have one in my pickup. I have one in the ambulances. This is your ERG or your emergency response guidebook. I can actually get on there and look up what that placard is based off the numbers and the symbols on it. And it is going to tell me everything I know before I go into that scene and take a breath of something bad, or before I send another crew into that, whether it be firemen or police or whatever. We have an idea what we're walking into. This allows us to get hazmat crews en route to us quickly also. Treatment for inhaled poison. So we want to remove that patient from the source of gas if it's safe for us to do so. If the patient's breathing, if the patient is not breathing, we want to do mouth to mask breathing. If the patient is breathing, administer large quantities of oxygen. Like I said, let's just flood them with those. Arrange for prompt transport. Once again, you're on the phone with us or the radio and you're going, hey, this is what they were in. This is what we're doing to treat them. We need to get this guy out of here as quick as possible. That just gives us a heads up. If you have not evacuated, you may have to evacuate large numbers of people first. So if we are in a warehouse or something and a vial of some toxic chemical breaks, first things first, let's get everybody out and away from that as quickly as possible. And then we can start that treating of people. We can triage from there. Injected poisons, there are two major causes of injection, poison by injection. Those are animal bites and stings and toxic injection. So, of course, we got spiders, snakes, bees, wasp, all that kind of stuff. That counts as an injection. I would rather play with a snake than a spider personally, but then we have toxic injections. People shoot themselves up with mixtures of chemicals and stuff to die. Signs and symptoms. So obvious injury site, snake bite or sting marks. You've got tenderness, swelling, redness, radiating from the injury site, which I'll hit here in a minute. Weakness, dizziness, localized pain and itching. I don't believe it says anything in here, but just a little hint and trick. If you identify that they were bit or stung, right here, this red streaking or radiating, and let's see, obvious injury site. So let's take our Sharpie or a pen as soon as we see that site and circle the outside of the redness. So we want to identify where it's at when we arrive. And what this does is by the time we get to the hospital, it will identify how much it's moving or the irritation area has moved from time that we arrive to the time the doctor sees them. Kind of calculate how fast it's spreading through the body. Treating insect bites or what snake bites, insect stings and bites, I'm sorry. Keep the patient calm and still. Wash the site with soapy water if you can. It says to remove using gauze wiped over the area or your fingernail. That's what your book says. I was actually taught to pull out your bank card, your Walmart card, your Sam's card, a hard plastic card, and actually kind of like scrape across that area, and it would pull that stinger out. never use tweezers, or, don't let your boyfriend or your uncle or anybody pop a pocket knife out and dig that out. We don't want to do that. Apply ice packs to that area. It helps with the swelling and the pain. And then some people may experience an extreme allergic reaction, which is called anaphylactic shock. So if this does happen, if we get a sting or a bite, we need to pay close attention once again to the respiratory system. We need to pay attention to their circulation. So they're ABCs, but if they start to form anaphylactic shock, then we have the red blotchy skin. We're starting to not be able to breathe. We feel like our throat's closing up. This is a late sign. This means we're in trouble. You definitely need EMS close by when this happens. So treat for shock. If you can, let's lay them down. Let's cover them up with a blanket to maintain body heat, and let's flood them with oxygen, non-rebreather, 15 liters per minute. Signs and symptoms, the anaphylactic shock, I kind of said a little bit of them there: itching, hives, swelling, wheezing, severe respiratory distress, generalized weakness, and unconsciousness. If we hit that unconsciousness, we're in bad trouble. We're treating for shock. If they have a auto injector EpiPen, we can go ahead and give that auto injector. Let's see, signs and symptoms. So once again, rapid weak pulse, rapid shallow breathing, decreased blood pressure, hypovolemic shock, or cardiac arrest can happen. Treatment, ABCs, administer oxygen when we can, and let's treat for shock. So real quick, let's go over ABCs because we don't want to forget them. Is our airway, is it open, or do we need to open it for them? B is breathing. Are they breathing adequately on their own, or do we need to breathe for them? Sometimes it's as simple as let's do head tilt chin lift. And then circulation, let's check their pulse. What's their pulse rate, and what's the quality? What's it like? Is it weak? Is it strong? Is it regular, irregular? Let's do cap refill. Let's go ahead and pinch that fingernail and let go. Should turn white to red within 2 seconds. Those are all very important. Treatment of anaphylactic shock, remove allergen if possible. Monitor the patient's vital signs, which we just talked about. If the patient's condition progresses to the point of respiratory or cardiac arrest, begin mouth to mask and CPR. So if they get bad enough that they die on us, yeah, we need to start CPR. Immediately arrange for rapid transport. Let's see, treating that anaphylactic shock, we've kind of talked about. If the patient is prescribed an EpiPen, let's go ahead and give it. If you're going to learn how to use the EpiPen in class. If not, get on YouTube. You can watch videos where you actually watch people do it. It's on the pen itself. There's a little instructions. You pop the caps off. You slam it into the thigh there on the leg. It injects. You hold it there for like 7 to 10 seconds, and then we're going to do a circular motion around the injection site, and that spreads that medication out through the system, and just works a little bit faster. We never leave our patient when we do this. We want to stay right by their side. We want to monitor their ABCs extremely closely, which we've been talking about. And we want to probably go ahead and have 911 on speakerphone right there and let them know what you're doing, because they're going to update the incoming ambulance. We get snake bites. There's 4 kind of venomous snakes in the United States. We have rattlesnakes, cottonmouths, copperheads, coral snakes. A snake injects its venom through a person's skin or muscle with its fangs. I think most of us know that. This poison can cause local injury to the skin and muscle, and may have involved to the entire, or may have effects on that entire extremity very quickly. So things we're going to look for is immediate pain at the site, swelling and tenderness around the bite, fainting from the emotional shock. Oh my God, I just got bit by a rattlesnake. You can actually go into a panic attack and pass out. Sweating, nausea, vomiting, shock. Once again, it doesn't say this, but I would go ahead and use my ink pen or my Sharpie, and I would circle that red area because we need to see how it's moving. Coral snakes deliver a slightly different poison and may cause these additional problems, so respiratory difficulties, slurred speech, paralysis, coma, seizure. So what does that sound like? That sounds like almost like stroke symptoms to me. So we've got to be very aware of what we're walking into, because we might be looking in the wrong direction. So we want to keep that patient calm and still as possible, have the patient lay down and try to relax, gently wash the area with soap and water if we have it. If the bite occurred on the arm or leg, let's splint that affected extremity, treat the patient carefully, and arrange for prompt transport somewhere where there's antivenom. Absorbed poison. This occurs when poisonous substances enter the body through the skin. Common absorption, insecticide, and toxic industrial chemicals. So these come in powders and liquids most of the time. Inflammation or redness skin is what we're going to look for. Signs and symptoms are chemical burns, rash, burning, itching, nausea, vomiting, dizziness, shock, or panic attack. Ensure the patient is no longer in contact with that substance. So if it's a dry powder, we want to brush it off with our gloved hand, with a broom. What do we have? Let's brush off all the dry powder before we rinse. We've all seen what flour and water does. You make a paste. We don't want to make a paste out of a chemical. So brush off everything you can before we rinse it. And then we're going to wash really good for about 20 minutes if possible. And in addition, EMS personnel are delayed. Contact Poison Control Center or your medical director if you have questions, concerns, comments. If the patient is experiencing shock, we're going to treat them the way we treat shock. We're going to lay them down. This says you can elevate the legs. You can. That's kind of an older practice, but we're going to lay them down. We're going to cover them with a blanket to maintain body heat, and we're going to give 15 liters per minute non-rebreather. If the patient is having difficulty breathing, administer that oxygen. If you're treating for shock, you're going to give oxygen. It's that simple. So nerve agents, I'm not going to pretend that I'm an expert on this, so we're going to kind of read through this. Nerve agents can be absorbed through the skin, inhaled, or injected. They are among the most deadly chemicals developed. Small quantities can kill a large number of people by causing cardiac arrest within minutes of exposure. The four most common are sarin, soman, tabin, and the V agent. Guys, I don't know very much about this stuff. So if you want to look this up on Google or whatever, that's awesome. If you want to do that homework, go ahead. So this sludgem, this is an acronym of things to look for. So salivation and sweating, excessive tearing of the eye, urination, defecation, drooling or diarrhea, gastrointestinal upset and cramps, emesis, which is vomiting, and muscle twitching, and pinpoint pupils. All of those are signs and symptoms we want to look for. Additional signs and symptoms are going to be shortness of breath, slow heart rate, muscle weakness, twitching and paralysis, slurred speech, seizures, and loss of consciousness. It is extremely important if you believe you are going to a nerve agent call. If you believe it might be a nerve agent, that we are protected. We don't want to run in and become one of the patients. If you're called to the scene of an nerve agent, okay, keep yourself free. Okay, I didn't know that it was fixing to say that. A well-trained hazmat team is needed for these things. And once again, the SCBA and encapsulating suits are needed for protection of responders. So we are not going to just run in there to save lives. That's one of the hardest things that you might ever face, is when you can see the people, or you can hear them screaming, or you can hear people yelling for help, and you cannot go do it. But remember, your safety is first. Let's see how to treat them. We're going to assess and support patients' ABCs after they've been decontaminated. DOT kit contains one auto injector syringe that contains atropine and some kind of chloride. Once again, I am not an expert in this. So read that chapter, read that section. If you've got questions, Katie might be able to answer them. If not, Google, YouTube, whatever. I'm going to tell you need to know this stuff, but it's not like, this is not nerve agent's not something you're going to be on a whole bunch of tests and stuff. Also, I don't want to tell you not to study, but don't waste time. According to the National Survey of Drug Use, 9.1 of the U.S. 9.1% of the U.S. population, that's 22 million people, have a substance abuse disorder. And that's alcohol and drugs. Substance abuse results in the increase in accidents and injuries and illness. The most commonly abused drug in the United States involves a significant number of fatalities. So alcohol is the highest abused drug. It's the highest reason for traffic fatalities at 31%, murders at 50%, and suicides at 33%. It's why we don't drink and drive. People get drunk, commit murder, and people who are suffering with depression and anxiety, they rely on alcohol, and it doesn't lead to suicide, but it does assist in leading to that. Symptoms of alcohol intoxication are similar to those of other medication, illnesses, and severe injuries. Be extra careful with your examination. Alcohol is an addicting, depressant drug. Persons physically dependent on alcohol can develop several, trying to blow my screen up so I can actually see the words because I'm old and I'm blind. Several withdrawal symptoms. Most severe symptoms are delirium tremors, or DTs. Signs and symptoms of these are shaking and restlessness, confusion, hallucinations, gastral distress, chest pain, fever. DTs are serious medical emergency and can be fatal. That's why it's really important that we talk to our family or the family members of the patient. We want to talk to bystanders. We run on someone who is acting funny or has just became overly aggravated all of a sudden when they're normally pretty calm, and the wife or the daughter or the son go, yeah, dad quit drinking 2 weeks ago, or dad quit drinking a month ago. He could be suffering from DTs. So that's why history is extremely important. So drugs may be ingested, inhaled, injected, absorbed into the body. Look for clues that indicate type of drug and why drug and way it was administered. So how did they take the drug? Abuse and prescription drug has increased in recent years. I'm not telling you to stereotype people. I'm going to tell you truthfully, when you walk into that scene and you make sure that scene is safe, there are a lot of times in these situations where you will see paraphernalia. You might see needles and syringes. You might see drugs laying on the table. I have seen this. It is possible. So be aware. And once you're in there, don't be touching stuff. Amphetamines stimulate the central nervous system, or the CNS. It includes speed, ice, crystal, cocaine, coke, crack rock, synthetics, stimulant type drugs such as bath salts. Signs of amphetamines use, it includes restlessness, irritability, talkativeness. Keep patients from harming themselves and transport them to a facility. I am going to go a step further and tell you, go ahead and get law enforcement. Just have them there. These people can just change personalities in a heartbeat. It could be a very dangerous situation. Yes, we're there to help these people, but we need to approach them very calmly, very softly spoken. We never accuse them of anything. Listen, which I think we talked about in chapter 1 or 2. Take the time to listen to them. They might make no sense, but you better be listening. It helps build that rapport, and they will trust you more. Pain relievers. This is an opioids and heroin. So hydrocodone, oxycodone, morphine, codeine. Most of these, I mean, you can have a surgery and get these and take them home. It's very easy to become addicted to them because they take away the pain. So we need to pay attention to opioids. This is when we're going to have the ability to use Narcan, which we'll talk about here in a second. Remember, though, that those are opioids. There are going to be some test questions, or there are going to be some scenarios, or these right here. are mentioned, and you have to decide if it's an opioid or not. Okay. Signs and symptoms: slow, difficult, shallow breathing or no breathing, small or pinpoint pupils, weak pulse, low blood pressure, blue nails and lips, drowsiness, disorientation, delirium, and coma. I highlighted these up here because these are the ones I want you to really pay attention to. That slow, difficult, shallow breathing or no breathing, definitely huge, huge, huge when it comes to a drug overdose of an opioid. And then the small pinpoint pupils are just kind of a final telltale. Handlement when we're talking about Narcan, this right here, the slow breathing, no breathing, shallow breathing, this is the indication, this is the red flag saying, yes, give Narcan. So here's Narcan or naloxone, same thing. A medication that can rapidly reverse the effects of an opioid drug on a central nervous system, now available for intranasal, I can't talk, administration or auto inject. So I can give this through an IV. I can give it through the nasal, which I've done, and I've witnessed the IV one. So we will talk about this a little bit in class because it kind of bothers me how they word this. Narcan doesn't really reverse the effect of opioids. So opioids go in and hit your receptors. So your receptors, picture it as like a keyhole to a door. Okay, opioids go through that door, they get to that nervous system, and it actually suppresses our respiratory drive. So what Narcan does, it goes in and it goes up to that keyhole and it locks that door so that our opioids cannot go through the door anymore. It blocks it so that our central nervous system isn't overwhelmed and our respiratory drive is not being shut down. So Narcan essentially is a bouncer. It stands outside those receptor doors and it stops opioids from getting in. So EMRs can give the medication only if they are trained to use it and it's within your local protocol. If you're okay through or approved through your medical director. So you got this atomizer, which is this little right there. That is your atomizer. It goes in your nose, and you push that medication in through the nostril. I think it's a half dose in each nostril. Check your protocols. Don't just take my word for it. You wait just a little bit. While you're doing this, you might be bagging them. You might be ventilating them. Hopefully this will bring them out of it and they will start breathing on their own. This is telling you how to give it, which I just told you. So it's 2 milliliters total. You're giving 1 milliliter into each nostril. You reassess the patient and document appropriately. Something we need to be careful of, which I don't know if it goes into it, is you have your intentional drug overdose. Someone just loves taking drugs and they took too much. And then you have your accidental overdose, which is grandma and grandpa who have 500 pills, which is called a polypharmacy, and they forgot that they took their pain pills. And so 20 minutes later, they take another one. And then an hour later, they're like, oh, I haven't taken that. And they take another one. Those are accidental overdoses. So we need to be careful because if we're taking away the effect of a pain pill from an old person, then they're going to wake up in extreme pain. So this is why you give a little dose and you kind of sit back and wait. If that little dose helps, that's great. If not, we can give the rest. We don't want to just slam the entire thing of Narcan in someone. They're either going to wake up and they're going to be superhuman strength mad at you, which I have seen, or they're going to wake up in extreme pain because we've taken away what controls their normal pain. So we're talking about fentanyl now. Follow universal precautions. We definitely want to wear our drugs. This can be a powder substance, so we probably want to put at least a surgical mask on, if not an N95. We don't want to use alcohol-based sanitizer. It might increase the absorption of that drug. If we're around fentanyl, one, yes, we probably need law enforcement involved. And two, we want to wash our clothes and get that off of us. It says here, use that N95. Consider wearing glasses or a face shield to protect your eyes. Hallucinogens like PCP, LSD. I don't even know what that one is. Mushrooms, anything that causes you to see things that aren't there. Some of the signs and symptoms, they're going to be crazy. I'll just say it like that. You're going to get maybe convulsions, coma, heart or lung failure, stroke. If they're alert or not alert, if they're awake, they might be just off their rocker. Try to reduce the audio and visual stimulants. I'm probably not going to run lights and sirens on this patient. I'm going to stay very calm and quiet. I want to keep them in my sight at all times. Never, ever turn my back on them. Approach each scene with caution. This is a dangerous situation. If we know what we're going into, we need law enforcement. And we might go ahead and call fire just so we got some extra muscle with us. And we want to arrange for transport safely and as calmly as possible. We need to approach these people very calmly. Abused inhalants, so intentional inhalation of violent chemicals. So this is going to be like your paints, your solvents, your brake cleaners, your engine cleaners. Squirt it in a paper bag and inhale it. These can be bought at hardware store, Walmart, anywhere you can get that kind of stuff. May cause some drowsiness, unresponsiveness, seizures, or sudden cardiac arrest. I'm going to tell you it can also affect the respiratory drive. Try to keep patient calm and still. And be prepared to ventilate, be prepared to do CPR on these patients. Inhaled or abused inhaled, support the ABCs. So we want airway open, breathing adequate, and we want good circulation. Give high flow oxygen if possible. So let's flood their system because they have now sucked in a bunch of chemicals into their lungs. And what's it doing at that alveoli? We're causing damage so that oxygen's not getting over into our capillary beds. So we really want to flood them with those. Carefully monitor those vital signs. We're going to take these vitals, every 2 or 3 minutes, we're getting a new set of vitals, and we want to arrange for that prompt transport. Toxic injection. So patient reaction depends on the quality and type of drug injections. Signs and symptoms: weakness, dizziness, fever, chills. Support the patient, treat the symptoms, provide transport to a medical facility, check injection site for redness, so it's circle, it's swelling, increase skin temperature because there might be infections if we're injecting ourselves. Maybe it's a dirty needle. As far as you and I are concerned, we want gloves. We want every protection we can get, and we are going to move with the purpose of we don't want infected, because these places can be dirty, they can be dangerous. These patients can be the same way. So let's pay close attention to our surroundings here. General treatment of the overdose, of a drug overdose, is provide basic life support. So ABCs all day long. I'm going to preach ABCs. Keep patient from hurting himself or others, him or herself or others. Once again, law enforcement is our friend. We're a team. Call law enforcement, have them help. Provoke reassurance and emotional support. We have got to stay calm. We do not judge people, which it says down there on the bottom. You treat them just like grandma and grandpa or mom and dad. Let's administer naloxone or Narcan if you have it and you've been trained to do so. Once again, we treat everybody the same, so let's avoid classifying or judging patients. Intentional poisoning. So we're going to attempted suicides, emergency treatment is the same. Patient will need both medical and emotional support. At this point, most people feel like there's nothing left in the world for them. We need to be extremely sympathetic. We do not judge them. We're sympathetic. We give them calm, collected reassurance that we're there for them. We listen to them. We allow them to say whatever they need to say. And we treat them like we would anybody else. So summing everything up, know the routes that you can have things. So we've got ingestion, inhalation. Yeah, my mind just went completely blank. Oh, I've got it over here in my notes. Hang on. So ingestion, inhalation, injection, and absorption. I should know it because I just taught it, but and know what they mean. Know the routes. Two major causes of poisoning is going to be injection, and that's from animal bites and stings, and two, toxic injection. Poisoning of absorption enters the body through the skin. Um, Nerve agents, like I said, don't spend a lot of time on that. Just kind of know what you absolutely have to. There's not going to be a lot of questions on nerve agents. Um, Pay special attention to scene safety and do not enter a hazardous environment without proper training. I can't preach that enough. Your safety, excuse me, is extremely important. It's you, your partner, and then the patient. So let's do this real quick. The most common route of poisoning is, we talked about it. It's ingestion. Okay. I didn't have a good example for that. Which of the following would not be considered appropriate management of anaphylactic shock? Administering oxygen, removing the allergen, inducing vomit, or immediate transport. So we do want to give oxygen, right? Anaphylactic shock, our airways closing up, we're not getting the oxygen we need to our body. So we're going to flood them with oxygen. We want to get them away from the allergen because it's what's causing it. So we need to get away from it. And then we do need to rapid transport because this is a critical patient at this point. We never, ever induce vomiting. Okay. Which of the following are common causes of carbon monoxide poisoning? I highlighted this for you guys, told you it was going to be a question. Is it air conditioning units, cleaning supplies, improper vented heat appliances, or paints and paint thinners? Yes, all of these could actually be the cause, but the leading cause or most common cause is C, that improper vented heating appliance. So guys, that was chapter 11. I think there's a lot there. If you've got questions, reach out to me. I'm happy to try to do some more research if you need me to. Otherwise, I will see you on chapter 12. So good job, and we'll see you here in a little bit.